All right. Good morning, everyone. My name is Juliet Knowles. I'm an assistant professor of child neurology and epilepsy at Stanford University. And I'm very excited to talk to you about our work on drug repurposing for SYNGAP1. And I think that introduction was a really amazing overview of some of the therapeutic modalities that are in the works for SYNGAP1. And just wanted to add to that I think those different treatment approaches will likely be complementary, and given the complexity of this neurological disease, we are likely going to need multiple tools to treat it. Okay, so I'll begin this talk with a brief overview of the Stanford Synaptopathy Program, which is a team of clinicians and researchers at Stanford that are focused on diseases such as SYNGAP1. I'll then show you some of our new pilot data using mouse models of SYNGAP1 to study two promising drugs for the clinic, phenylbutyrate and nortriptyline. And I'll discuss some next steps and future directions. So in the genetic epilepsy clinic, where I spend a lot of my time taking care of patients, we frequently see epilepsy, autism, and intellectual disability. And we often see these features co-occurring in the same person. And a major genetic cause of this constellation of features is the synaptopathies. These are neurological disorders that arise from pathological variants in genes that govern synaptic function, such as SYNGAP1 and SDXBP1. And most of the rest of this talk will be about SYNGAP1. And as many of you well know, SYNGAP1 encodes a protein that's required for synaptic development and function. And haploinsufficiency of this protein results in a highly penetrant, severe childhood onset generalized epilepsy, and a host of other challenges: neurodevelopmental delay, behavioral abnormalities, sleep disruption, autism, and movement disorders like ataxia. So in 2023, my colleague at Stanford, another pediatric epileptologist, Chrisley Messer, and I were talking about the challenges that these children and their families face with Mike Graglia and Charlene Sun-Rigby, the founder of the SDXBP1 Foundation. And it became clear that there isn't really a clinical expert home for children with synaptopathies on the West Coast. So with that great need in mind, Chrisley Messer and I founded the California Synaptopathy Clinic at Stanford in 2023. And the goal of this clinic was to provide expert, comprehensive, and cutting-edge care for children with synaptopathies and their families. And then this year, we took another big step forward when we were fortunate to join the STAR natural history study of SDXBP1 as a site at Stanford. And as many of you know, this study is being funded by the SDXBP1 Foundation, and the PI of the study and chief architect of the study is Ingo Helbig from CHOP, who's here today. And one reason that this was such a good step forward for us is that setting up the natural history study enabled us to also set up a multidisciplinary clinic for the STXBP1 patients. So this is just a typical visit template for our patients. And when they come in, they spend time with a neuropsychologist or psychiatrist, a PT, an OT, a genetic counselor, and a neurologist at minimum. And now we want to replicate this experience, this multidisciplinary clinic care for our SYNGAP1 patients. So we're applying to be a site for the forthcoming natural history study in 2025. And when this started a few years ago, it was just me and Chrisley Messer leading the charge. But now we have a growing team that includes 3 pediatric epileptologists, a amazing multidisciplinary clinic team, additional scientists who are bringing complementary expertise to help us build a robust translational research program around the clinic. And of course, we've been guided at each step by Mike and Charlene, who as amazing patient advocates have helped us to set our priorities for research. And the rest of the work that I'm going to show you now has been done by 2 wonderful postdocs in my lab, Dr. Azeen Amini and Kala Nair. So My lab has many projects where we focus on fundamental pathogenic mechanisms of epilepsy. But as we were launching this multidisciplinary clinic, we were particularly drawn to highly translational questions and projects that would address some low-hanging fruit in the field and potentially even change the way we take care of our patients in the near future. And that was the rationale for the drug repurposing studies that I'm going to tell you about. So in my lab, we used two different mouse models to study SYNGAP1. The first model bears a knock-in splice site variant in SYNGAP1, and this model was published by the Huguenier lab in 2023. And they demonstrated that these mice have haploinsufficiency of SYNGAP1 and cognitive impairment, but the epilepsy phenotype had not yet been described. So Dr. Amini used 24-hour video EEG to characterize the epilepsy phenotype in these mice. And she found that similar to children affected by SYNGAP1, these mice have generalized seizures that are progressive over time. So you can see here that the seizures become more and more frequent between postnatal day 60 and postnatal day 120 in the mice. The second mouse model that we use is a heterozygous knockout model, and the epilepsy phenotype for these mice had already been published by Shilpa Kadam in 2020, and she showed sort of a similar timeline where these mice have progression of their epilepsy between P90 and P120. So this is a representative video EEG from one of these knockout mice. And just to orient you, this bottom trace is the EMG. So this shows muscle activity, and these deflections represent movements of the mouse. And then we have EEG brain activity recordings from the motor cortex and bilateral somatosensory cortices. And I think you can appreciate that in this mouse's EEG, there's this constant coming and going of this generalized spike wave discharge pattern, similar to what we see in children with SYNGAP1. I think you can also appreciate that when this spike wave discharge becomes prominent, the EMG flattens out. So there is, some degree of behavioral arrest during these prolonged periods of spike wave discharges. And so these spike wave discharges resemble atypical absence seizures that we often see in children with severe generalized epilepsy. So the first drug that we studied is phenylbutyrate. And phenylbutyrate is FDA approved for use in children with urea cycle disorders. But interestingly, it's shown efficacy in other preclinical epilepsy models, including SDX-BP1 and SLC6A1. And in fact, there are clinical trials ongoing of phenylbutyrate for genetic epilepsies, including SDX-BP1, SLC6A1, and SYNGAP1. And I think you may hear about those later today. The possible mechanisms for the therapeutic effects of phenylbutyrate involve its protein chaperone effects, HDAC inhibitor properties, and kinase inhibitor properties. And we were particularly interested in the HDAC inhibitor properties of phenylbutyrate because in previous work, we demonstrated that HDAC inhibitors may prevent generalized epilepsy progression. So this was a different study using a different mouse model of severe generalized epilepsy. And what I'm showing is that we randomized these mice to either vehicle or an HDAC inhibitor called trichostatin A, TSA. And just prior to starting treatment, we recorded EEG from these mice, and they had equivalent seizure burden, as you can see there. However, after 2.5 weeks of treatment, the mice that had received vehicle had substantial progression of their epilepsy with increasing seizure burden, whereas the mice that received TSA had significantly fewer seizures. So TSA prevented epilepsy progression. Unfortunately, TSA has a high toxicity profile and would not be suitable for treating epilepsy in children. So Dr. Nair in the lab set up what was designed to be a prevention trial to prevent epilepsy progression using phenylbutyrate. And she randomized wild type or heterozygous SYNGAP mice to either vehicle or phenylbutyrate administered at 100 mg per kg per day. And this was based on the other preclinical studies. This was the same dose used in those studies. And she treated them every day between P90 and P120. And these time points were selected because this was the previously published timeline of epilepsy progression. And she did EEG, behavioral testing, and brain tissue collection. So at our first look at the EEG data, we were a little bit surprised and disappointed that we didn't find any evidence of a therapeutic effect on seizures. In fact, the mice that received vehicle had about a 50% increase in their seizure burden over that 1 month period, and that was similar in the phenylbutyrate-treated mice. So we thought about this a little bit more, and we went back and looked at the SYNGAP1 heterozygous mice in our lab in our own hands. And we found that in contrast to what had already been shown, the mice that we have actually have progression of their epilepsy between P60 and P90, whereas those that received phenylbutyrate, whereas we treated mice with phenylbutyrate at later time points, P90 to P120. And if you think about it, if your hypothesis about the mechanism of an HDAC inhibitor is that it's going to prevent epigenetic changes that underlie epilepsy progression, then you probably need to be giving it during this period of epilepsy progression. So these were important lessons from our first pilot study that we'll use moving forward. But we also examined other endpoints. And it looks like some of the formatting is off from the slide. So I'll just walk you through this. So one of the behavioral tests that we used was the social interaction test. And in this test, mice are placed in a chamber, and then they have the choice to explore either a chamber with a new mouse that they've never met before or an empty identical chamber. Healthy wild-type mice prefer to spend more time exploring this new mouse and will spend less time in the empty chamber. And so this test is thought to be a readout of sociability that's impaired in autism. And what we found was that heterozygous mice treated with vehicle had spent significantly less time in the social chamber, whereas those treated with phenylbutyrate, this deficit was completely corrected. And we saw the same pattern when we looked at the same data in a slightly different way with the social preference index that normalizes the social exploration time to the total exploration time. So we're excited and somewhat encouraged by these pilot data using phenylbutyrate. And our next steps are to complete the analysis of secondary endpoints in this first pilot study. And then we look forward to repeating this study again, but designing it more as a prevention trial, so starting earlier. We're definitely interested, as was pointed out in the introduction, in exploring the therapeutic mechanism of phenylbutyrate related to its HDAC inhibitors properties, for example. And we've been talking along the way with Zach Grinspan, who is conducting a clinical trial or multiple clinical trials of phenylbutyrate. And we may need to optimize our dosing a bit because we've learned from Zach that higher doses of phenylbutyrate are needed for epilepsy efficacy. So the next drug that we looked at was nortriptyline. And the rationale for this came about from a high throughput drug screen that was done by the Silicon Valley company Rarebase, now known as Transcripta Bio. And I believe this work was actually shown at last year's conference. So this is a nice follow-up on that. So this drug screen included 1,500 FDA-approved drugs. And they used a human iPSC neuronal platform to screen these drugs. And of the 1,500, they found that 38 induced upregulation of SYNGAP1 expression. That's gene transcription. And the lead compound from these 38 was nortriptyline. So nortriptyline is a tricyclic antidepressant that was approved by the FDA in the 1960s for treatment of major depression. And it's also used for a few other indications in adults and in children. The mechanism is it's a serotonin and norepinephrine reuptake inhibitor. And the reason that it's no longer a first-line medication is that it does have anticholinergic, antihistamine, and alpha blockade effects that can cause some side effects that we'll need to be aware of. The typical dosing when this drug is used in children is 1 to 3 milligrams per kilogram per day. And I think it's particularly prudent to do further preclinical testing of nortriptyline in mouse models because there's a controversial relationship between tricyclic antidepressants and seizures. When nortriptyline was first approved in the 1960s, there were small studies and case reports indicating that tricyclic antidepressants might actually trigger seizures or lower the seizure threshold in normal and epileptic individuals. But then after that, there were contradictory small studies indicating actually anticonvulsant effects of tricyclic antidepressants. And then a 2023 meta-analysis indicated no clear association between antidepressants and seizure risk, but cited limited evidence. So I think it's a valid question. What would be the net effect of a tricyclic antidepressant like nortriptyline in SYNGAP1? So with these questions in mind and thinking about a potential clinical trial, Dr. Amini in the lab has conducted a pilot study of nortriptyline for SYNGAP1. In this case, we did design it as more of a reversal trial, giving this drug to mice with established seizures, because we reasoned that this might be the situation that we're in if we were to do a clinical trial in the near future. And so she administered nortriptyline 3 mg per kg per day, a clinically relevant dose between P120 and P150 when we know these mice already have seizures. And we weren't adequately powered to definitively measure a beneficial seizure effect, but we did find a promising trend in which vehicle-treated mice had an increase of about 20% in seizure burden over this treatment interval, whereas the nortriptyline-treated mice actually had around a 30 to 40% decrease in seizure burden. And again, when we looked at the social interaction test, we found that vehicle-treated mice had decreased social exploration, and this deficit was completely corrected by treatment with nortriptyline. So we're really excited and encouraged by these first pilot study results for nortriptyline, and we look forward to replicating our reversal trial with first greater statistical power. We're working on optimizing the dosing with some pharmacokinetic studies, and we'll continue our secondary endpoint analysis. And an important aim is to determine whether nortriptyline upregulates protein expression in brain tissue of these treated mice. We also are considering a prevention trial, and you'll hear later today about exciting planning in the works for a clinical trial of nortriptyline in children with SYNGAP1. And so with that, I'd like to thank you very much for your attention. I'd like to thank our collaborators and our funding sources. And of course, I want to say thank you to my lab at Stanford, including Dr. Nair and Dr. Amini, who did the painstaking work on these pilot studies. Okay, thank you very much.